Thank you very much, sir. I invite Dr. Amit Ghosh to open the meeting with his opening remarks. Thank you.
Good evening, everybody. Thank you, Ravi. Thank you, Lakshman. I think it is very important that we are hosting this meeting in a old wine in a new bottle. It is nothing new. And therefore, it is very important to realize that this Uro Onco section is a very, very important section. Though we should not actually discriminate from one to the other, the reality shows that once it was announced, there was an instant huge number of membership that immediately logged in. We have nearly got 350 members now. So it comes with a lot of responsibility. And we are aware of that. We are trying to make the best utility of that. One or two things I need to clarify at the very outset. This Uro Onco section, as we understand it, is open to everybody who is interested in Uro Oncology. He may not be, by definition, a Uro Oncologist. A huge number of our members practice Uro Oncology along with others. So this section, you can take membership if you are practicing even a fraction of your practice in Uro Oncology. However, there has been a stricture from the main body and the council that if you want to become a faculty, you have to become a member. Audience can be anybody. Irrespective of all these rules and regulations, I think it is extremely important to all of us to be interested in this subject because this is the future. Nothing is the past, but this is the future. So we appeal to everybody, try and inculcate the spirit of membership of Uro Oncology section in their friends and their colleagues, whoever they meet. This is an appeal from my side and from the team to all of you. The benefits of joining will come true as we go along, but there are immense benefits. Number one is the professional benefit about the subject of Uro Oncology. But beyond that, this is a platform to connect, both with the nation and the world, for greater opportunities, both in training, in participation, in fellowships, in networking. And today's mantra is networking. So with this, we had a very, very short time. We were very, very unfair to Bhushbhanu Nayak today. We've thrust the responsibility on him to host the first ever meeting on a notice of 5 days. And we've today, before we even start, we've got a participation in this webinar of 67 as we speak, which is a very high number. This is being watched, as you've heard, by people all over the nation, all over the world and beyond. Therefore, best wishes to, we will want your blessings to have a very vibrant future all over the year. We are very delighted to announce that on the 9th and 10th of June, we are hosting an annual meeting, which will be physical. And we've chosen the institution of AIIMS Rishikesh with organizing secretary Ankur Mittal, who has agreed to shoulder the responsibility. And I'm sure this is going to be a very charismatic meeting. With these words, I pass it on to Ravi Mohan to carry on the meeting.
Thank you, sir. Thank you for those opening remarks. Without wasting much time, I think most important thing for us for any of such meeting is to maintain a strict timeline. So without wasting much time, I invite Dr. Bhushbhanu Nayak, who is an additional professor of urology at AIIMS New Delhi, to start the meeting. Dr. Nayak.
Good evening. Thank you, USI, and thank you, Uro Oncology subsection, for asking me basically for the opportunity and also for the responsibility to conduct as a moderator first inaugural webinar for 2023. So as they have already spoken, it was actually only very short time, 7 days time to conduct this. And Dr. Ravi told me if you can have 60 audience, then that will be a good start. So I think we have already done 70 are already there. So actually, today's discussion will be on non-muscle invasive bladder cancer. There will be two specific talk, and after that there will be panel discussion, and the panel discussion will be specifically focusing on those two lectures. So I have 4 eminent panelists. So my first speaker will be Dr. Jiten Jaipriya. He actually was a consultant in Rajiv Gandhi Cancer Institute. Currently, he is doing his fellowship on focal therapy for prostate in, I think, UCH or Imperial Hospital, Imperial College of London. I don't know exactly. I'm sorry. You can just tell that. And he will be speaking on management of BCG on responsive non-muscle invasive bladder cancer. I would request all the speakers please stick to the time. And after Dr. Jiten Jaipuria delivers his lecture, then Dr. Sudhir Rawal will be giving his expert opinion on this. Thank you, Dr. Jiten, please.
Thank you so much, sir, for the kind introduction. So I am currently a senior clinical fellow with Imperial, dealing with urological cancers, including robotics and focal therapy. So topic for today is BCG unresponsive options. So I don't have any conflicts of interest relevant to the talk. Now, the outline for the talk will be, first, we will try to define what we mean by BCG unresponsiveness, and then we understand the available options, and then we will deal with the practicalities involved. I have emphasized recent literature and phase 2-3 trial data, which has full publications. There are a lot of phase 1 data with abstracts, which I have not taken in consideration because they're not there, in the immediate next radar. So the problem statement is that approximately 1/3 of non-muscle invasive bladder patients will not respond to BCG. And even in those that will respond, more than 50% will experience recurrence or progression during long-term follow-up. So you are going to deal with this problem where BCG has not worked. And if we look at the natural history of such patients, we find that approximately 31 to 47% of these patients, without subsequent treatment by means of radical cystectomy, they go on to progress. So the 5-year disease-specific survival, it drops to 80% and then keeps dropping further as each year goes on. Now, before we talk about what BCG unresponsive means, we need to understand what an adequate BCG means. So it has been defined by US FDA for trial purposes. You should have had at least 5 of 6 doses of an initial induction course, plus at least 2 of 3 doses of the maintenance therapy. So if that has been done, you have had enough BCG to then decide whether it has worked or not. Or if you had gone for the second induction course, then even if you had only 2 doses out of the planned 6 for the second induction, and then you're good to decide whether BCG has worked or not. So this is the definition of adequate BCG. Now, the philosophy why this BCG unresponsiveness was thought of, because we wanted to define a subset of patients where subsequent BCG should not be tried. So we want to, if it means BCG unresponsive, there is no role of further BCG by definition. So if you look at the philosophy, let's say if someone has taken full 3 years induction plus maintenance course of BCG and then relapses, that intuitively is not such a bad prognosis versus someone who is relapsing right after 3 months of initial BCG induction course. So these two subset of patients are quite clear, late relapsers versus very early relapsers who we call as refractory or resistant. Now, what we realized over time was that there is still another, bigger group of patients who are not immediately refractory, but they still don't do well. So these are the kind of patients, for example, you have given an adequate BCG and then you see at 6 months they are failing, or within 12 months CIS is happening. So these are the kind of patients who also don't do as well. So they are kind of in a similar group to where, BCG failed right upfront at 3rd month. So unresponsiveness is a bigger umbrella term that incorporates resistance or refractory patients within itself, plus more. So there are different societies which, promulgate different guidelines and definitions for what they mean by BCG unresponsiveness. The 2 major ones are EAU and FDA, although they are now cooperating with each other to harmonize it. if you understand the philosophy, BCG unresponsive would include, according to EAU, everyone who is BCG refractory, or if you have a high-grade relapse, no matter T1 or TA, within 6 months of adequate BCG treatment, or if you have a CIS within 12 months of adequate BCG treatment. FDA definition is slightly more restrictive and has some more subpoints. I won't go into detail of that. But the important thing is we want our definition to be a bit wide, because there are studies actually which show that you should not leave out patients who are not likely to respond well to BCG because they all don't behave well as a group. So my recommendation is to follow the EAU definition and not the stricter FDA definition, which leaves some patients out. There are also definitions by Society of Immunotherapy for Cancer, SITC, and International Bladder Cancer Group, which are also roughly similar. You can choose them as well. Out of this, International Bladder Cancer Group is good for research. But again, EAU is what I would say is the standard definition. If you look at the current guideline recommendations for BCG failure across different societies, the important thing is you need to not offer additional BCG. Secondly, you need to strongly consider radical cystectomy as the first line options. This is the crux of what they all essentially say. If you include BCG relapse, which is basically you gave entire BCG and then you had a tumor coming after finishing all maintenance course, then you can, if it is a late relapse, consider repeat BCG. But otherwise, the mainstay is don't offer further BCG and offer radical cystectomy. So the mainstay treatment option is very clearly radical cystectomy. It provides the greatest opportunity for cure with disease-specific survival rates appearing 80 to 90% over the long term. And it also allows to cover those patients who you think are NMIBC, but they could actually be NMIBC because 20-25% or even higher number of patients actually upstage when you finally do a cystectomy on them. It also enables lymphadenectomy, and that also may have benefit if the disease is still occult to the lymph nodes. And then it obviates the need for further intravesical therapy if you are, not removing the bladder and giving still instillation. So radical cystectomy just simplifies the follow-up. So these are the advantages. But, in clinical practice, you will often face patients who are unfit for a radical cystectomy or who then just don't want a radical cystectomy. So there is a role for other options. So like I said, if you understand the definition of unresponsiveness, there is no role of playing further with BCG as per definition. Historically, there were first attempts at combining BCG with other things like interferon alpha. In meta-analysis, proven useless. There were also attempts to, use MCNA, which is mycobacterium clay cell wall nucleic acid complex to treat. Now, in the initial studies, it was actually quite a good result. It rendered 61.2% patients with papillary tumors, not CIS, papillary tumors, disease-free. But the FDA during those days, it said insisted on a phase 3 data and declined its approval. So it's worked somehow, but it has not been approved. Next came attempts to play with intravesical chemotherapy. So mitomycin was already mainstay in low risk group, and intermediate it had an optional role in vis-a-vis BCG. The first one was valrubicin, which was approved quite a decade ago. And although, now this is surprising, FDA approved this because it was shown to work in heavily pretreated patients and even those that had CIS, although the 12-month complete response rate was only 13%. So FDA kind of, because it was a phase 3 data, they said, fine, we'll allow this. Then there were other options also that were tried. Gemcitabine was another one. In the initial 3 months, the results were quite good. 47% patients were disease-free. But as the year came close, the response rate dropped to 28%. Docetaxel was also tried around about the same time. Similar data, 1 year recurrence-free survival was 40%. But somehow this docetaxel didn't really pick up steam because people quickly moved on to combination of gemcitabine and docetaxel, which I'll shortly cover. Paclitaxel was also tried, and it was followed up longer. And as expected, as you follow these patients longer, at around 41 months, only 20, less than 20% patients ended up, still having no recurrence. So in summary, these mono agents, they all showed good responses at 1 year, but then as you follow up longer, it kind of dropped down to 20-30% range. So gemcitabine plus docetaxel was then tried in a multi-institutional experience was published, which was a retrospective analysis. There is no prospective data on gem-dosi. And we, in India, there's actually a good attempt with PGI and other institutes collaborating to do a prospective study on this. So this had a better result than individual gem and dosi, where 1 and 2 year recurrence-free survival rates were 60 and 46%. So this is a good outcome of the research, which hopefully we will soon accomplish in India. In US, another combination was tried where they added Kawasi, gem, and cisplatin together in a small number of patients with 18 patient study, where the initial partial and complete response rates in BCG unresponsive were 94 and 89%. So it's quite a heavy regimen, although it doesn't penetrate systemically, and the response rates are good, but the numbers are small. This is worth trying in a bigger study. Then we also tried, giving chemotherapy in a better way. So chemotherapy was tried. So this is a synergy system, which has a thermocouple at the tip of the catheter, which, using microwaves heats up the chemotherapy, which is mitomycin and delivers. Now, this didn't do well in patients with CIS. It was only working in non-CIS papillary tumors, but not in CIS. In India, we have a different type of chemotherapy, hyperthermic, which is high-rate, where the machine heats up the solution right at the machine level, and the catheter doesn't do any active heating. So heated solution goes into the bladder, achieving 41 degrees Celsius. So again, this kind of works in CIS as well as non-CIS. And recurrence-free survival rate is 53.1% at 1 year, but again, at 2 years, it again drops down to 20%, as you see in the monotherapy regimens. There is another way to give, which is electromotive drug administration, where you attach an electrode on the abdominal wall and it kind of, interferosis occurs and the drug penetrates the epithelium better. Now again, in CIS, the efficacy drops down, but in T1, G3, you see at 3 years follow-up, the results are quite good with nearly 70% response rates. I would say this is superior, but it's not there in India. Then the next advancement came via introduction of immunotherapy. Now it kind of works in non-muscle invasive bladder cancer because what BCG does is induces a heavy immune response, and then immunotherapy agents, they actually help overcome the BCG resistance, because one of the mechanisms of BCG resistance is PD-1 expression. So pembrolizumab was given FDA approval, which was given systemically for BCG unresponsive patients in Keynote 057 trial. They had 2 cohorts. One group of patients had unresponsive CIS, along with, and the other cohort had non-CIS but papillary tumors. But in this, you need to give pembrolizumab every 3 weeks for 2 years, and the complete response rates are somewhere in the range of 40% for both cohorts, and this now we have around 3-year data. So this has been FDA approved, backed by phase 2 data. Now, the other option that has been tried is atezolizumab. It was initially tried in the SWOG 1605 trial, where again, in 3 months, the complete response rate was 41%, but in 6 months, it dropped to 26%. And this was not doing well in CIS patients. When atezolizumab was combined with BCG, and this was reported very recently, then the 6 months complete response rate was 33% compared to 42% in atezo plus BCG arm. So this was significant. Now, the next important advancement came with novel strategies. So adstiladrin has been recently FDA approved. This is basically an intravesical adenovirus vector-based gene therapy. What it does is, where BCG plus interferon initially failed, as I told before, because interferon, you void it quickly into urine. This therapy ensures that the bladder epithelial cells start making interferon, and that allows the constant interferon alpha-2b intravesical concentration to be achieved. So this was shown to achieve 53.4% complete response rate at 3 months in BCG unresponsive NMIBC. And in patients without CIS, it was even better. It was 72.9%. Hence, FDA approved this. The other thing was CG0070. So this is another conditionally replicating oncolytic adenovirus. So this replicates in retinoblastoma pathway defective bladder tumor cells. And then it works by two mechanisms. The virus itself causes damage, and then of course it also induces GM-CSF expression because these cells they have defective expression of GM-CSF. So this has been shown to work quite well. Two trials came. One where this was tried as a monotherapy, where 6 months complete response rates were quite good to 47%. And when this was combined with pembrolizumab, the results were brilliant. The complete response rate at 3 months was 87.5%. This is a very recent trial. Longer term data is accumulating, and this may in future, is quite likely to get FDA approval. The most recent breakthrough occurred with interleukin 15 based immunostimulatory fusion protein complex, which was AMPTEVA. So it promoted proliferation and activation of natural killer cells, but not regulatory T cells, which kind of dampened the immune response. And this was given accelerated approval for BCG unresponsive CIS because of the trial, which showed because of the QUILT 3.03 trial, which showed an excellent 99% bladder cancer specific overall survival at 2 years, where in CIS patients, the complete response rate was 71% at the end of 2 years. This is an unheard of result. This has exceeded all other options that we have so far had experience with. So this was given accelerated approval, and it is being tried in further combinations. So the future looks quite promising. The other way scientists are trying is with antibody drug conjugates, where Vicinium oportuzumab drug antibody conjugate has been tried. So what it essentially does is it targets the EpCAM molecule, where the toxin, which is basically Pseudomonas exotoxin A, is delivered into cell, and then it kind of kills the cell. So this was tried in the Vista trial, which was reported prior to the pandemic, where there was a 42% 3-month complete response rate. Beyond that, we don't have updates. Now, as we understand the biology of cancer better, there are a multitude of agents that are under trials. I won't be discussing them because most of them are phase 1. But we have things like imiquimod, which is a general immune modulator. Then we have which is basically a bispecific antibody. Then we have more antibodies against PD-1, PD-L1. Salimumab is part of it in CREST-1 trial in Imperial. Then there is Leonardostatin mesylate, which targets the tryptophan pathway. So, and there are also antibodies against FGFR and other pathways as well. So there is a wealth of trial data that is soon going to hit us with all the results. But the important question is, is all this being translated to clinical practice as we sit in 2023? So this was a survey of clinicians all over the world just published last year. And you will be surprised that even when we know what BCG unresponsive means, majority of the patients around the world get continued to be treated by TURBT and further BCG. So this is something we need to change. Now, this is my concluding slide. So how do we apply all that we learn to clinical practice? First of all, don't get confused. None of the newer agents that have been proven to work are superior to radical cystectomy in any way. So these are only options where you can't do radical cystectomy or patient declines for radical cystectomy for whatever reasons. So you only consider these if RC is contraindicated or decline. The options that are feasible in India are Hyvec and Jamdosi. We already have some experience with in India. Both of these are not backed by, I would say, prospective data, which is specific to us or even around the world. Jamdosi has no prospective data at all. Hyvec has. Systemic immunotherapy, pembrolizumab, is the only option which is practical in India. And I think some institutes do offer this. It is backed by FDA approval, and I would be preferring this if the patient has CIS and cost is not an issue because you need to give it for 2 years. Even in UK, we practice systemic immunotherapy as our first line option because there the guidelines need to be followed quite strictly. So thank you. These were observations on the recent trial data. I will leave you with these two slides, which look at ongoing trials where, a lot of exciting combinations are being tried of the agents that I mentioned and all the agents that were there in a pictorial that I was trying to show, which work at different levels in the immunostimulatory pathway. Thank you.
Thank you, Dr. Jitan, for an extensive talk. And though there was a little bit of a disturbance in the audio, but we could actually get the crux of the talk. So I would request Dr. Sudhir Rawal sir to just give his comments on this talk.
Thank you, Brushbanu, and thank you, Jitain, about your elaborating talk, especially theoretical, and telling what are the options in India available. Problem with these patients is that most of the things which are there in West we do not have except that gemcitabine or maybe the pembrolizumab. But pembrolizumab per se is very costly. Another thing which we had the trial for these patients and we could not recruit even single patient was ardoferitinib, which you did mention in one of your slides. But then it's very difficult to identify these patients, as 15% of the patient will be having only FGFR mutation.
Correct.
And we could not give any patient in this trial. This has been stopped. But the thing which you have said in last is the most important, because when you see the patient who has got high-grade non-muscle invasive disease, multiple lesion or lesion more than 3 centimeters, better you convince the patient that you will require cystectomy if you fail the BCG. You may try BCG, and if a patient is ready, offer the cystectomy in the beginning only, because this is like, we always say that it is like wolf in sheep herd. There's the same thing as these patients, and many times these patients will be ready for cystectomy if you actually convince them in the beginning, because these patients, when they fail BCG, they will definitely be ready for cystectomy rather than any other treatment. But some of these patients may insist for another line of treatment like gem-doce or maybe gem-interferon, which may not be that effective. So better to have low threshold for these patients of cystectomy rather than offering the another line of treatment in India in our setup. But maybe in future, few of these patients may land up with ardoferitinib, that FGFR mutations, when then you can try these drugs. But as on today, better to convince these patients in the beginning for cystectomy. Thank you, Brushbanu.
Thank you, sir. So we're moving to the next talk, but before that's just one question, or the audience question. If Dr. Jitan, you can take that question. Is there any histological findings in NMIBC which can predict before you start BCG whether this patient is going to respond to BCG or not? So that's a question from the audience, Dr. Onil.
So if you want to predict BCG even before trying BCG as a first line, I don't think there is anything that is practical at the moment. Theoretically, I can say that if the tumor mutational burden is high, if the PD-1 expression is high, these patients are likely to fail BCG quite quickly. But I mean, no one really does any genomic profiling prior to BCG installation. So everyone will get BCG all over the world. But when BCG fails, now this is an important situation. Here we recommend that you do tumor profiling. And like Dr. Naval was telling, it was there in Rajiv Gandhi when the FGFR study came. So all these novel agents that I mentioned, it is recommended that you do your tumor profiling. There are ways to individualize therapy, although PD-1 expression, even if it is low, on the pembrolizumab and nivolumab, it kind of works. Although it's more numerically the results are low, but statistically not. So you are going to give even if the PD-1 expression is low or high. But the other ones like FGFR and others, you need to test those markers.
Okay, yes, Dr.
Can I say something?
Sure, sir.
See, if patient, there are 2-3 factors which you have to see where you should not offer BCG, or you ask the patient that better to go for cystectomy is multiple tumor. If the tumor is more than 3 centimeter, and if the patient has got recurrence, or if there is micropapillary variant, there are few situations you should insist on patient to have cystectomy
basically
rather
what you are
than go for
talking about
BC.
is European highest risk category, EU highest
Yes.
risk category variant.
Yeah,
Yes.
highest risk. Yeah, I agree. I agree. Correct.
Yeah, so now we move on to the next topic. Maybe Dr. Santosh will actually address to sort of these questions in his talk. The role of molecular markers in management of NMIBC. I think he will be speaking in general, not specific to the NMIBC. He will speak both NMIBC and MIBC, the role of molecular markers. Dr. Santosh, please.
Yeah. Hello, am I audible, Dr. Naik?
Yeah. Yes.
Thank you very much, Dr. Naik, Dr. Ravi, Dr. Ghosh, and Dr. Prabhu for having me here. I can see my friends, Dr. Bakshi here, and senior faculty, Dr. Rawal, Dr. Seth, and Dr. Kashyapi here. So the topic given to me today is about molecular pathology. Generally, this is a very heavy and to be called quote unquote toxic subject when we talk about heavy molecular, but I'll try to make it simplified and little clinically oriented in my talk. In next 15 minutes we will discuss on this. So we look at the urethral carcinoma. These are the general features, and I will not go into the details. Low grade papillary is the commoner variety of urethral cancer, and this is just a pictorial representation of how flat lesions and papillary lesions look like. The dangerous one in the flat lesion is the carcinoma in situ, which is nothing but a high grade lesion, but which is still not on a papillae or a finger like projection when it's seen in the bladder, and usually like a carpet like growth which is seen. And then you have the papillary growths with the low grade and the high grade, and this is how the pictorial representation is. So if you look at NMIBC, it accounts for 75% of the bladder cancer tumors, but it has to be very clearly understood here that it's a very heterogeneous group. When you talk of NMIBC, it includes both low and high grade non-invasive bladder cancer, along with T1 tumors. Most of the 98 to 97 to 98% of T1 tumors, when you look at a pathology report, would be high grade. If it is written as low grade T1 tumors, you should question your pathologist in your daily practice. And all these tumors, this heterogeneous group, have got a variable recurrence and progression rate. We all know that. So which are the urethral cancers that the urologist is worried about? It's definitely the muscle invasive bladder cancer. And then there are some aggressive non-muscle invasive bladder cancer, which are the subtypes of non-muscle invasive. And obviously all the high grades. So once the urologist hears about these three things, he's really worried that these patients are the problematic ones which are going to progress slowly. Coming to the subtypes, or what used to be known as the variant histology, they are known now no longer called as variants, they are called as subtypes. They were categorized into two types. That's the divergent, which includes the squamous glandular, another like small cell, and the variant histology, which is the micropapillary, plasmacytoid, adenocarcinoma, nested variants. What is the significance of these subtypes? Now, the understanding these are histological, but mind you, they are also molecularly heterogeneous. So these subtypes, they have specific molecular signature also, and that is well known now. That's why I'm dealing with this now. As high as 20% of these can show subtype or divergent differentiation. The most important understanding is whenever you hear the report that it's a subtype like a micropapillary or a squamous or a neuroendocrine or small cell, you have to think that this is very likely to be a muscle invasive presentation. So that's the importance. Even though the report says it's NMIBC, when you hear that it's variant histology or subtype histology, you must think that it's a muscle invasive. And the biological behavior is different in these subtypes. The commonest one are the squamous. The important understanding for the clinician that these are very responsive to PD-L1 therapy, especially in the metastatic setting, and they're very characteristically picked up by the pathologist. The micropapillary, Dr. Rawal referred to this, they present at advanced stage, and even in T1, non-muscle invasive stage, many of these micropapillary ones, they can present with nodal metastasis, and you can pick them on CT scans. And they can be candidates for early NACT or early cystectomy. Nested variant, your report might sometimes say low-grade urethral carcinoma, nested type. So you should be careful. They look nested, but then they are, most of the times they are muscle invasive, and they are a huge problem when it comes. But thankfully, they constitute less than 5% of the bladder cancer subtypes. Plasmacytoid, very strange kind of tumor, very look like plasma cells in the lamina propria. They may be muscle invasive presentation, but many a times they may be difficult to picturize in pathology, and they have strange patterns of recurrence. So these are some types which you need to know. Small cell, everybody knows they are very aggressive. So even if they are non-muscle invasive at presentation, it should be thought of that these are probably going to progress or already muscle invasive presentation. What are, in the molecular era, what are the questions we need to ask? Why is molecular information needed? What is the current available information? When to ask for these tests? What are the tests? What tissue to be used? Is it a primary tumor, metastatic tumor, fresh versus formalin fixed tissue? The cost is generally exorbitant and unaffordable for most of the low income setting. And most important again, the expertise is limited and resource and infrastructure is needed to do these tests. So why is this molecular information needed? We all know that not all urothelial cancers behave similarly. Some are very aggressive. We know that there are aggressive NMIBCs. Not all MIBCs progress aggressively. The response rate to BCG, NACT is different in these. So we have a responder group and a non-responder group. We just had a talk by Jiten about this. And then there are question of bladder preservation, which are the best suited candidates. And also in the era of immune checkpoint inhibitor, which are the best candidates. So what do we currently know about the molecular subtypes in bladder cancer? And what is the progression of understanding of molecular genetics? So this is a slide I borrowed from Dr. Ashwin. We know that in 2006-7, we developed the NGS techniques. Before that, it said we know the role of FGFR and the TP53 and RB protein in muscle invasive bladder cancer. So this was known. The NGS opened a new era where we could sequence a lot of exomes and a lot of genomes throughout. And that's when we came to understand a lot about the molecular pathology of bladder cancer. In a nutshell, if I want to say, I can say in 2 words, the basic 2 pathways are the luminal papillary pathway or the low grade kind of pathway, which it's a misnomer, but we call it a low grade pathway. It is mainly based on FGFR mutation. So the low grade papillary tumor which you see or which you come across in your clinical practice is generally an FGFR pathway tumor. Whereas the high grade T1 tumors, high grade muscle invasive tumors, generally come to the P53 or the high grade pathway. So this is in general, in a nutshell, if I have to say, the 2 major molecular pathways which give rise to different kind of. The papillary pathway gives rise to low grade papillary kind of tumors, whereas the high grade pathway, the P50, gives rise to CIS and the high grade invasive tumors. So what do we have in NMIBC? The issue at hand is the tumors may look similar under the microscope, but they have widely different molecular features and may belong to different molecular subgroups. And this is the understanding which we are having over the coming era, and we will have to face this, and the treatment may be tailored according to this in the coming. If you look at certain papers which turned out the UA prognostic risk factor stratification, they looked at this and they found that it is dependent on the number of tumors, the tumor size, age, and I'm sure you all know this. And they found that the probability of progression varies in these kind of prognostic risk scoring from 1 to 40%. So molecularly, NMIBC they have tried to classify based on some immunohistochemical panels like P53 and Ki67, but these have been met with very limited kind of practical utility in day-to-day practice. There was another paper, you can see that the paper is in 2013, 10 years have gone by, and they have done a lot of studies, but none has come into actual day-to-day practice when it comes to stratifying NMIBCs. Again, there have been recent papers in clinical cancer research which have found that FGFR mutation status and methylation of GATA2 can help in stratify this NMIBC risk group into a good risk, moderate, and a poor risk criteria. The problem with this is these are difficult to practice in day-to-day practice, and they may not actually translate into exact correlation. If I look at TCGA, which came into 2005-2006, they were divided into 4 clusters. The cluster 1 was the papillary tumor with FGFR alterations. The cluster 2, which had the which are similar to the cluster 1 but had other markers like GATA3 and FOXA1. And then there is a basal squamous. The earliest attempts were the MSKCC dataset, which divided bladder cancers into 2 major groups, the luminal and the basal line. So if you want to take home some message from this talk, the most important understanding is that bladder cancer are broadly molecular divided into luminal, basal, P53-like, and the null type kind of phenotype molecularly. It is important to know that because these are different outcomes, the survival graphs are here in front of you, and the overall survival and the disease-specific survival are different for this basal, P53 and luminal. These can be picked up on certain immunohistochemistry, and we'll discuss in a later slide. But mind you, all the immunohistochemistry does not 100% correlate with actual molecular testing. So actual molecular testing is important to delineate these categories. Why do you want to know about the basal luminal? Because the difference in this platinum-based chemotherapy between this basal luminal and P53. You can see that if you look at this graph plot, can see that the basal ones are good responders to platinum-based chemotherapy, whereas the P53-like and the luminal-like are not great responders. So that's one thing. Then we had this Lund et al. And Jodal et al. Classification, in which again the bladder cancer was divided into Eurobasal A, Eurobasal B, infiltrated, and several other categories based on a specific gene signature. And all of these have different outcomes. What am I driving at? I'm driving at the fact that under the microscope or in your pathology report, you may find it as an NMIBC or MIBC, but under the molecular classification, these are different categories with different outcomes when it comes to their survival. So in 2020, European Urology, this was a very major paper which came together and used all these different classification from Lund, from MSKCC dataset, and they came up with a basic result. And this is the current understanding of molecular classification of bladder cancer. It is basically divided into 6 different categories, in which 3 of them are luminal type, 1 is basal, 1 is stroma rich category, and 1 is a neuroendocrine, on what we see under the microscope or report as a small cell. So this is the basic molecular classification. It is applied to muscle invasive bladder cancer, but mind you, many of these would begin as a non-muscle invasive bladder cancer. So this is the basic 6 categories, and they have got a different histological characterization. So the basal type of urothelial cancer looks squamous under the under pathology. LUMP or papillary type has a papillary histology. The non-specific luminal type has the micropapillary histology and is also associated with a lot of CIS. And the neuroendocrine-like molecular classification is seen as and reported as a small cell histology. So they have got a phenotypic kind of a correlation. So there is a genotype-phenotype correlation in these. But then to actually go to the bottom of this molecular classification, you'll have to do high-end genomics to get to the bottom of this. So these have different overall survival. You can see that the luminal papillary has the best survival. Then you have the luminal unclassified ones. And then the worst ones are the neuroendocrine and the basal squamous type. A very important slide from the clinical point of view. These molecular subtypes are now being targeted with different therapies. So if you look at the luminal papillary type, it is generally an FGFR3 driven tumor. And a given setting, say in a recurrent low-grade kind of luminal papillary tumor, you can definitely target them with FGFR therapy. Whereas if you compare with basal and squamous kind of tumor here, you can see that they are EGFR targeted therapies, immunotherapies, and chemotherapies work well in squamous carcinomas. And neuroendocrine, we know that the immunotherapy and radiotherapy work well in them. So difference in this molecular subtyping, when we get to the bottom of it, when we understand that, we can really tailor make the treatment for these tumors. In daily routine, we can try and replicate this molecular classification on a day-to-day practice using immunohistochemistry with GATA3, CK56, P16. We can try to divide into 4 distinct subtypes like basal, uro, the genomically unstable, and the urokeratin 5 type of tumors. When it comes to MIBC, then again we can use these IHCs. But mind you, this can classify tumors up to a percentage of 80 to 85%. There'll be 15 to 20, 25% tumors which will not be able to classify it, which will have overlapping in this IHCs. And that's where the limitation of immunohistochemistry comes in a day-to-day practice when it comes to molecular classification. So this is the summary of targeted therapies we have discussed. PDL assessment, I would not go into the details. It's a very confusing kind of a field in when it comes to urothelial cancer. We have to use adequate controls in pathology lab when we are reading PDL1. And if you look at the different drugs, like atezolizumab has got a different scoring system, pembrolizumab has got a different scoring system. There are different clones of PDL1 which are used. There are different kinds of platforms which are used when we have to report on this PDL1 therapy. So to end my talk, I would just say that next time when you get a report of a urothelial carcinoma, you should spare a thought on their molecular heterogeneity. Whatever, maybe there were 2 reports, 2 cancers, look same under the microscope, reported similarly, maybe totally different molecularly. So that thought should come into your mind. A basal and luminal may be attempted with keratin 5-6, GATA3, CK20, CK14. We do try to do that. But mind you, when we try to do this in daily practice, there is a lot of overlap amongst these tumors, and it may create a lot of confusion in the mind of the pathologist as well as the clinician. Before I end, you should remember that there are 6 major molecular classes of bladder cancer in the current era, which have come from the paper in 2020 in European Urology. Papillary tumors are the best. The luminal papillary, to be precise, are the best. They may be FGFR targetable with erdafitinib. Squamous carcinomas belong to the basal category and may be amenable to immunotherapy. Micropapillary may be a good candidate for neoadjuvant chemotherapy or an early cystectomy. And PD-L1 testing in platinum ineligible patients is important biomarker when you look at treatment of this bladder cancer. Thank you so much.
Thank you, Dr. Santosh, for a very nice talk on molecular subtyping. And I would request Professor Amlesh Seth, sir, please give his expert comment on the talk and also his view on molecular subtyping in management of bladder cancer.
Thank you, Prashanu. Thank you, Santosh. Santosh has done an excellent job. It's a very complex subject and he has simplified it to a very large extent. I would just re-emphasize some of the points that he has already made. We all know that for decades we have been looking at these tumors cystoscopically and they all look so different. There is a complete spectrum. There are some which are so beautiful, they look just like the sea anemone, these are the ones that have the best prognosis. The more arborized, the best, most beautiful looking tumors, they are the ones that have they have the best prognosis. But if we come to dome shaped, flat, these are the ones that are more sinister and they have a poorer prognosis. And this is how Santosh started. He started his slide with division into flat and papillary and extensive papillary versus less papillary. So and then after that, you know, now there are the TCGA Atlas study has shown the fantastic, the large spectrum of genetic variations that these bladder tumors have. The genetic variation load that bladder tumor has is much more than any other cancer, and that has led us to the understanding that the originating cell, although it is from the urothelium, but the urothelium is not, all the cells are not exactly the same, although they may look same, but the basal cells are different from the luminal cells. And the luminal cells, if they turn tumorous, they have a better prognosis. The basal cells, if they turn tumorous, then they are more likely to go into the muscle, and therefore by these genetic studies you can differentiate. And Santosh has also made the things simple by saying that although you can use simple IHC, the GATA3, FGFR mutate, and then you can, based on the simple IHC, you can have some idea whether these are basal or they are luminal. And then the basal types are more likely to be muscle invasive to begin with. And if they are not muscle invasive to begin with, they are more likely to progress to muscle invasive. They are the ones that need to be looked at very carefully, and more aggressive treatment has to be given. The basal, although they have a poor prognosis, they are likely to respond to chemotherapy better. And the other point which Santosh emphasized is another very relevant point, and that is that these are the subtypes of urothelial carcinoma. They are not, variant histologies. So that is, the initial thinking was that there may be a differentiation of the urothelium into one type, but they are different types of malignancies, all put in one basket of urothelial carcinoma or bladder cancer. Actually, not strictly speaking urothelial carcinoma, bladder cancer, because squamous is definitely different, and sarcomatoid is definitely different, and small cell is also definitely different. And in these and plasmacytoid and micropapillary, these 5 variants are more aggressive and they have to be treated with more aggressive therapy. And in the last slides, Santosh has also pointed out that the treatment strategies will also depend upon the subtype. Like you may have to choose immunotherapy for certain tumors, and intravesical therapy for certain tumors, and straightaway surgery for certain tumors. And that kind of an understanding is also increasing with the molecular subtyping. Congratulations to Santosh for making us such a complex subject relatively simple. And there are a few questions in the chat box that I would like to kind of comment on. The first question that was asked was, hello? The first question that was asked was that whether a deep muscle biopsy should be sent separately or not? If most people would do TURBT separately, and a deep muscle biopsy should be sent separately to the pathologist, or what I personally think, which is not being practiced, is you should video record the TURBT and send it to the pathologist, because the pathologist should see the gross tumor and how you have resected, what all you have resected, and then the labels that you have put on the biopsy. The pathologist will get a very good idea regarding what to look for and how to report, and that would be a great help to the clinician. Another question that was asked in the chat box, all NMIBC with squamous differentiation need to be treated as okay. This has already been answered. I think most of the other questions have been answered in the chat box. But if there are any other, if there is any other question that anybody would like to ask, I'm sure Santosh would be very happy to answer.
Okay. Thank you,
Otherwise,
sir. But
thank
now
you very much.
Yeah, I will move on to the next session, that is a panel discussion, but I would request Dr. Seth and Dr. Sudhiral also to be there. So my esteemed panelists are Dr. Rajiv Jadhav, Dr. Ganesh Bakshi, Dr. Palachandra Kashyapi, and Dr. Giridhar Bora. I don't need to introduce any of them. I think almost all of you know these four urologists. So I'll just straight away start with the case. Most of our discussion will also be basing upon the BCG, unresponsive disease, and also the molecular subtyping. So this is a 62-year male chronic smoker with intermittent painless gross hematuria for 2 months. He has no prior history, no comorbidities. The examinations are normal. His blood chemistry were normal. So he came with this ultrasound, which shows multiple hypoechoic lesion in the bladder. Bilateral kidneys are normal. So the first question to Dr. Giridhar Bora.
Nayak, in your share
can
screen,
you make it full screen?
Entire...
To make the slides full screen. Yeah.
I am actually making it full screen. Let me start again.
Yeah, again, reshare it again.
Just the case maybe.
Can you see it now?
No, you can see your slides sorted kind of view. So if you can go back to the PowerPoint and bring to the individual slide mode, then you will be able to share it.
Or you can open the same mode, slide sorter, and you see on the top there is slideshow.
Full screen, yes, slideshow
from the beginning.
Can you see it now?
No.
Now we can't see anything.
Just a second.
Yeah.
We can see it now.
Can you go back to the first slide?
Yeah. Can you see it now?
Yeah.
Yes, but go back to the first slide now.
So this is the class side.
No, it's past history and examination here. Yeah. Before that.
The slide after the panelists.
One slide up.
Can you see it now?
No.
No, it has not moved.
No problem. We got the history.
We are still not seeing the full screen. It was just the primary slide. Make it full screen, maybe we will be able to see.
So you can put the slideshow and start from the beginning.
I actually did slideshow from the screen.
Okay. Sorry
From
then.
the screen, I'm making it slideshow.
We are not seeing it that way. No problem.
Can you tell me which slide you are seeing now?
Your photo.
Kashan, up your picture. Yeah.
Only my picture?
Yeah.
No,
That's like okay.
We are okay.
Yeah, clinical scenario.
Okay. Is it okay now?
Yes, okay, no problem.
Okay, he's a 62-year male chronic smoker with intermittent painless gross hematuria for 2 months. He had no prior history. There is no comorbidities. Examinations are normal. Blood chemistry normal. He came with the ultrasound which shows multiple hypoechoic lesion in the bladder.
Slide is not moving.
Bilateral kidneys are normal. It's not moving.
I think you go on. I mean, we'll hear the presentation. No problem.
Yeah.
No, but you need to see that, no? Can you see the ultrasound image?
Not yet. Not yet.
Not yet.
It is not with.
And
Okay,
now
we can.
so there's a lag, it seems, Dr. Nayak. You continue with the presentation. Let the panelists take us the question, and the lag will take care of itself.
Okay. So he came with an ultrasound which shows multiple hypoechoic lesion in the bladder. The bilateral kidneys were normal. So the first question to Dr. Bora: so do you require any further investigation to plan your management for this patient? Patient came with hematuria, ultrasound showing multiple lesion in the bladder. Do you require any further investigation to plan your treatment?
Since the patient is having multiple tumors, he will require a CT scan at some point of treatment. Whether we can do a TURBT first and then later on do a CT, or we can do a CT scan first if the patient is not having any gross hematuria or currently.
So is it, in other words, is mandatory to do a CT abdomen and CT abdomen and pelvis before you do a TURBT, or you can do it after TURBT?
Yes, we can do it after, because these looks like a small tumors. We can do a TURBT and most likely looks like a non-muscle invasive in this thing. But to evaluate the upper tract, and there are multiple tumors, it's better to go for a CT scan in this patient.
Any further investigations, or only CT scan is enough for you?
I think renal functions, blood test and a CT scan is enough.
Okay, now Dr. Rajiv Jadhav, sir, do you want a CT scan before or after? And even if you want a CT scan before, what are the cases where you advise a CT, and what are the cases you can straight away go with an ultrasound only? Basically, what are the specific indications where you need to do a CT before you do a TURBT?
Well, personally, I would like to get a CT scan before proceeding to the TURBT. The reason is that once
Dr. Rajiv Yadav, I think you
cannot hear you
properly. You are logged in from two devices. There is an echo.
No.
There is some problem in your audio.
Okay, so maybe I was.
Can you say that again?
I'm
not able to hear you properly.
Rishbanu, can I take that question till Rajiv gets onto the?
Sure. Dr. Kashyap, can you answer that question?
So in addition to the ultrasound, I want a urinary cytology also. That is the first thing, because sometimes high-grade cytology, and if finally the report comes as low-grade, there is a mismatch. So I need to look at the upper tract also. And a CT scan, first I would want, if it's a very bulky tumor, especially if there is any hydronephrosis, that is, I would definitely want a CT before. In this patient, there is no hydronephrosis mentioned. These are multiple tumors. It's better if you can have a CT before.
Okay. So the next question to Dr. Ganesh Bakshi. So are you okay with a CT scan, or do you want an MRI with virate scoring before you plan your treatment?
Currently, I am okay with the CT scan. MRI with virates is well known nowadays, and it is still evolving. I think probably at many centers, the radiologists themselves are not geared up for routinely reporting a virate score. So if it is virates where we are doing it for extravesical disease, it's very simple. But the CT shows us the same information.
Okay, so we'll discuss about virates, what are the potential indications. But actually the question was also for Dr. Kashyap, what is the practical utility of doing a cytology in a bladder tumor which is detected on the imaging, and how commonly it has changed your management in your clinical practice? By doing a cytology when there is an imaging showing a bladder tumor, how routinely, how commonly the cytology has actually altered your management?
So the answer to that is, if the cytology is positive generally in high-grade tumors, and you do a TURBT and if the report comes as low-grade tumor,
I understand that. I'm just asking how commonly it has happened with you in your clinical practice. I understand the logic you're talking.
Maybe 10% of the patients.
Okay. So maybe I will ask Dr. Seth this question. So, sir, what is your... Yes, sir.
The main issue is, based on the ultrasonogram, whether you think that this is going to be a low-grade non-muscle invasive disease or is it likely to be muscle invasive disease. If there had been a single tumor, such small tumor, I would say the likelihood of this being non-muscle invasive is high. But since there are multiple tumors, any one of them may be muscle invasive. And I agree with Dr. Kashyap that urine cytology should definitely be added. And if urine cytology is positive, I would definitely like to go in for an imaging. Now, which imaging to go for? Looking at these small tumors, CT scan may not be a very good imaging modality to tell you the depth. So if I have to advise an imaging to this patient for looking at the upper tract, CT scan is a very good investigation. If there are any filling defects in the pelvic ileal system, CT scan will tell that. But for depth of invasion or suspicion of depth of invasion in this, MRI with a high B value in T2 weighted images is likely, in diffusion weighted images, is likely to be more specific. So going by what are our recent experiences, that if this patient has to be subjected to an imaging, I would advise an MRI.
Yes, so let's actually discuss. So what's the potential indications of doing an MRI or virus? There are two specific potential clinical implications of virus and MRI. One is for initial bladder cancer risk stratification. The other is for better patient selection if you are actually considering for bladder sparing trimodality therapy. For bladder cancer risk stratification, suppose a patient where you have done a TURBT, to decide whether to go in for a restage TURBT and delay the intravesical therapy, or you can directly go for intravesical treatment. So MRI can actually help you deciding whether to do a restage or not. Suppose, say for example, a patient with a solitary tumor less than 3 centimeter, histopathology comes out as T1G3. So as per all the guidelines, any patient with T1G3, even if it's a solitary less than 3 centimeter, those patients should undergo a restaging TURBT. Even if the histopathology, there is muscle present, but it was not muscle invasive. So in spite of muscle being present, those patients should undergo a restaging TURBT. But if you have done an MRI beforehand and the MRI viral scoring is only viral 1 and 2, the likelihood of upstaging for this patient would be very, very less. So maybe these are the patients where you can avoid a restaging TURBT and go in for intravesical therapy without further delay. But in another situation, if this is a small T1G3 less than 3 centimeter tumor, but the viral scoring is 4 and 5, the likelihood of upstaging for those cases will actually be higher. So in those cases, it is always better to do a restaging. So MRI in that case might actually help us in deciding whether to do a restaging or not. In another case also, if your primary tumor is multiple T1G3 with lymphovascular invasion, as for the European guidelines, all these patients, there is a scope for early cystectomy. But if you have done an MRI and that shows viral 4-5, that also helps you in counseling patient for early cystectomy. So these are the two potential indications of how MRI can help. And also, if you see, if you are considering patient for a trimodality therapy, bladder sparing treatment, so you should actually its idea is to decide whether this patient is actually T2 or T3. If it is T3, T4, those patients are not suitable candidate for bladder sparing approach. So MRI can actually better discriminate between T2 and T3 or T4 than CT. So MRI will help us in deciding who are the patients there for a good candidate for bladder sparing treatment.
Dr. Nayak, sorry, the slides are not moving.
I'm sorry. Can you see anything now, or you are not able to see anything?
We are stuck at the ultrasound report.
Something is wrong. I'm really, really sorry.
So, Dr. Amlesh said, sir, have you changed practice totally and gone for MRIs in NMIBCs? Or you select again?
No.
Because
no, it's not like that.
The small tumors which
no.
you said for the depth, actually we'll do an investigation with the cystoscopy TURBT.
Yeah, the standard guideline would be, if you the thing is that earlier CT scan and MRI were much more expensive and less sparingly available. Now these are available so easily. Although it may not be in the guidelines, but as a clinical practice, I think there is a value of doing MRI for this particular individual.
I agree. But overall, as a blanket thing, I don't think we have still accepted
I agree.
doing an MRI in guidelines.
As a blanket thing, as a guideline for the students, this is not what I would agree.
I think
if they have to answer in the exam, I would say whatever Dr. Balchandra Kashyapi has said, that is what they have to answer. If the tumor is more than 3 centimeters, if there is hydronephrosis, if there are multiple tumors, then they are supposed to advise a CT scan. But in this panel discussion, we are also trying to discuss the recent advances. And as a recent advances in terms of thinking, CT will not give you a good picture. The picture that CT will tell you is, something which will be as good or as bad as what is seen on this ultrasonogram.
I agree with that, sir. Yeah. So problem when we discussed this at large at TMH was that there is a big observer variability, and many radiologists across the country are very easily able to read the CT scan. That was a big thing which was there. Again, what Dr. Nayak said, that we can have MRI and have all these things changed. And the MRI is done at a baseline, actually. And we still are probably not using all these as individual, to guide future treatment till now, at least. I think we should get out meaningful studies which are wishful and try to change these into, as Dr. Brisbane was saying.
Okay, go ahead.
Actually, since you are not able to see my slides, so it is very difficult for me.
Now we are seeing your slides. We are seeing the take home right now.
Yeah, exactly. So the take home is MRI with varied scoring is an emerging modality for evaluation of bladder cancer with some potential clinical application. But as in today, CT, MRI both are cross-sectional imaging of choice, but MRI has not replaced CT scan as the imaging modality of choice. So that is what I wanted to tell actually as my take home for MRI in bladder cancer. So anyway, this patient then underwent a CT scan. This is a CT urogram of the patient, which shows, you can see on the left side, there are tiny tumor on the left lateral wall, and this cross-sectional imaging also shows there is another tumor on the right post-lateral wall. So there are multiple tumors. So the question now is, Dr. Ganesh Bakshi and Dr. Balachandra Kashyapi, both you can take Dr. Ganesh Bakshi first. Would you recommend doing a conventional TURBT, or would you recommend doing an en-bloc TURBT, and why?
I myself have been doing en bloc TURBTs only in very small tumors where, they are just in 2-3 loop movements they get out. Otherwise, I'm doing a conventional TURBT and probably quite okay with that. Why? I really think that where en bloc may be actually necessary, where we are actually wanting that morphology in one piece in slightly bigger tumors, there we are unable to bring them probably out. We might cut them in various ways inside after having that en bloc big tumor, or use a morcellator. So the whole logic is lost. And then my good friend Dr. Santosh Menon is here, which I had discussed with him for a real long time. He said, he always says that if a pathologist is good, you are anyways going to get that anatomy right when I'm reporting. So I never felt the need to exceptionally always go for an en bloc TURBT in all my practice of all these years.
So Dr. Kaushik, do you have a different opinion, or do you agree with him?
Most of the time I would do a conventional TURBT, and I'm quite happy with it.
Okay, so before we come to that, what is the current consensus on that? I will ask my second question. Dr. Rajiv and Dr. Bora, do you recommend doing a white light cystoscopy and TURBT, or would you ask to do a blue light cystoscopy or a NBI while doing a TURBT?
Well, we do white light cystoscopy, although theoretically blue light and NBI is a way to pick up more flat lesions and maybe increase the yield. But in practice, white light cystoscopy is something which is widely available, practiced by everyone. What we have recently moved on is the newer image system from stores, where you can do a post-processing and get the almost the same benefit of doing a narrowband imaging. Otherwise, majority of the cases we are doing white light cystoscopy.
Okay, Dr. Bora?
Yeah, I agree with Dr. Rajiv, because most of the TURBTs are done under white light cystoscopy, unless it's under some research study or a trial or a project in our department. We usually do white light cystoscopy.
So we'll see what the current role. If Dr. Rahul is there, Rahul sir, can you give your comments on this?
No, I agree with both of them, Girdhar Bora and Rajiv Yadav. We are doing white light cystoscopy routinely, but in very rarely we do blue light. We use blue light, which is there in in Rajiv Gandhi also, but we probably do not require most of the time. It's very popular in Europe and some places in America, but somehow we are not very convinced as of today.
Okay. So before we move on, let's see what the literature tells about whether do a conventional or en bloc TURBT. This is a systematic review and meta-analysis. Is the en bloc TURBT more effective than conventional dissection? This particular meta-analysis has actually concluded the hospitalization time, catheterization time, and 2 years recurrence rate is superior in patients treated with a en bloc dissection than conventional TURBT, and the en bloc dissections have a lower complication rate. So the literature is actually very confusing. This is a meta-analysis which showed this is superior. But if you go a little bit deeper into this meta-analysis, most of the studies actually are retrospective and few prospective studies, only one randomized controlled trial. And in most of these cases, the size of the tumor are actually less than 2 centimeter, solitary tumor most of the cases. However, if you just look at that randomized trial that actually included in that meta-analysis, this particular randomized trial actually has shows the operation time was longer in laser en bloc TURBT, and the operator now reflects, though it doesn't happen with laser TURBT, this was more common with conventional TURBT. They concluded the tumor recurrence, there is no significant difference between actually conventional and en bloc TURBT. Though the meta-analysis which has included this particular randomized trial, along with other retrospective study, has actually giving a different conclusion. This is again another randomized trial. This randomized trial has shown there is no difference in the recurrence rate between en bloc and conventional TURBT. And most of the patients in en bloc TURBT with laser TURBT actually have required a re-TURBT because the muscle specimen were actually absent. However, these investigators actually pointed out the muscle specimen were absent in their initial series of their initial laser TURBT, the initial specimens. But this is again another meta-analysis. This again says the en bloc TURBT has a significantly lower hospitalization time, intraoperative and postoperative complications, and the 2-year recurrence rate than those treated with conventional TURBT. But again, this particular meta-analysis has shown 4 recent randomized controlled trials actually has shown there is no difference in terms of either 1 year or 2 year recurrence rate between en bloc or conventional TURBT. So finally, this recent meta-analysis, this is actually meta-analysis of only randomized controlled trials that was published in August 2022. This actually has shown there is no difference in the conventional TURBT and en bloc TURBT as per the recurrence. And regarding the quality of the specimen, as many would claim the en bloc TURBT would have a better quality of the specimen. These 4 randomized trials, the meta-analysis of those randomized trials actually have shown there is no difference in the quality of the specimen, and also the perioperative complications like the catheterization time and hospitalization time, there was no difference. So basically, as per the en bloc and conventional, en bloc TURBT is an emerging technique, but actually it's not feasible to do en bloc TURBT in most of the cases. It's difficult to do in anteriorly located tumors, and mostly it's feasible in the size is less than 3 centimeter and posteriorly located lateral bladder, but not very feasible to do it in the anterior one. As per the role of whether we should do a only white light cystoscopy and TURBT, or we should use blue light cystoscopy or narrowband imaging. This is again a meta-analysis which has actually shown all the cancers that has dissected using either 5-amino levulinic acid based photodynamic diagnosis or hexa-amino levulinic based photodynamic diagnosis or NBI used resection. All those patients have a lower rate of recurrence than those who are treated only using white light cystoscopy. This is another systematic
5 more minutes.
Yeah, this is another systematic review which was published very recently by Dr. Kamath and Dr. Mir Desai in the McGill. They have actually also recommended the same TURBT either using PDD or NBI at a greater sensitivity, and they underscore this should be integrated these technologies as the standard of care for patients with NMIBC while dissection. So this was the cystoscopy finding of that particular patient. This patient underwent a conventional TURBT. My question now to Dr. Bora: do you routinely give perioperative intravesical chemotherapy to all patients, or do you have any specific indication on and when do we give it? What specific agent do you recommend?
If it's a small papillary tumor and you completely resect it and you on a look of it, it looks like a non-muscle invasive tumor, then we give a perioperative mitomycin C after the procedure.
Dr. Rajiv, do we have, yes, Dr. Rajiv, do you have any specific comments on this? Do you recommend only mitomycin, or do you have any specific preference of other agents like gemcitabine or maybe distilled water? Many literature actually has shown distilled water also is okay.
It's quite a standard of practice to use mitomycin in most of the cases. First time presenters, small tumor, papillary, looking like superficial low-grade tumor. We always give mitomycin within the first 2 hours, preferably. Whenever the resection is not deep enough where we suspect perforation, we avoid it. Although literature do say that gemcitabine can also be used with good evidence, but in practice we are using mitomycin just simply because we have been using it for quite many years.
Dr. Bakshi, do you have any experience on gemcitabine? Okay, this is actually
using mitomycin for most of my patients.
Okay, actually, this is a paper on randomized trial, SWAG randomized trial, comparing gemcitabine with saline. And based on this randomized trial, NCCN actually is recommending gemcitabine as the first line for perioperative intravesical gemcitabine during after TURBT, and it actually has put it under preferred category over mitomycin. And though we have actually randomized trial, there is no direct comparison between different intravesical agents. So we are actually conducting a randomized trial comparing gemcitabine with mitomycin in our trial. The histopathology was T1G3 lymphobascular invasion, no CIS. Now the question is Dr. Manish Bakshi again and Dr. Balachandra Kashyapi. Is there any role of molecular markers for this particular patient? I think you have already heard the talk. Any specific role of the molecular markers?
I mean, not a direct role in trying to manage this patient in the current time.
Not at this stage.
Dr. Kashyapi?
Not at this stage.
Okay, so we'll just move on. So this is a review on molecular markers in bladder cancer. Very briefly, I will tell the tissue markers for non-muscle invasive bladder cancer. There are 2 meta-analyses which have actually summarized the role of P53. If somebody was asking how can we just predict the responsiveness of the BCG before we start it? So there are 2 meta-analyses which have summarized the role of P53 in NMIBC. Which has actually shown the overexpression of P53 in NMIBC can predict the progression in T1G3. However, it cannot predict the response to BCG. These patients actually are likely to progress if they are P53 positive, but it cannot predict whether by just being P53 positive, they will respond to BCG or not. Hence, the current recommendation is the tissue biomarkers for NMIBC is currently not recommended since it doesn't change or improve your clinical decision making. But as for the muscle invasive bladder cancer, Dr. Santosh has already spoken. But for muscle invasive bladder cancer, molecular marker has actually potential role in clinical decision making. If you can actually find out if this patient is actually luminal or basal variant, if the patient is having CK5-6 positive, that falls under basal variant. If it is GATA3 positive, this falls under luminal variant. The luminal variants are very responsive, have a very good prognosis and overall survival. The basal variant, though they have a poor prognosis, but those are the patients who respond very well to neoadjuvant chemotherapy. So once you know in muscle invasive bladder cancer, if you know this is a patient of basal variant, you can put them to neoadjuvant chemotherapy. If you find it's a luminal, since those patients do not respond to chemotherapy, you can actually avoid giving chemotherapy and delaying cystectomy. You can directly counsel them for cystectomy. So yes, luminal and basal variant, if you can subclassify in NMIBC, they are actually going to change the management. So for take home is for NMIBC, routine molecular marker subtyping is not recommended. For MIBC, molecular subtyping has clinical application. So the question is now again to Dr. Rajiv Jadhav, do you routinely re-stratify your NMIBC?
Could you wind up in the next minute or two? Because I think we have to stick to time. Because
do you routinely re-stratify your NMIBC patients in your clinic and mention those in the OPD cards? Or do you just think this is a high risk and then put it and advise the treatment? Or do you routinely recommend that in your OPD card?
So unlike PGI Chandigarh, we do not have a OPD card or a booklet. What we do is we mention regularly in every visit in our electronic record system, and it is prominently displayed what was the initial stratification and what is the plan of action and how far we are following it. So it has to be prominently displayed every time the patient visits.
Okay. Dr. Bora, do you routinely use any risk calculator like URTC, Kyoto to prognosticate the patients, their chances of recurrence and prognosis and progression?
As I agree with Dr. Rajiv, we do stratify our patients on low risk, intermediate, and high risk group, but we don't use a risk calculator or prognostication of the patient. You know, it's a busy OPD day, but we do risk stratify the patients to guide the treatment.
Okay, Dr. Bakshi, you do recommend a restage for this patient, or is it always mandatory to do a restage TURBT?
It is recommended to do a re-TURBT. However, in real practice, we see if there are high volume centers who are doing re-TURBTs or the results have been different. I mean, the TURBT done at say your center, which is a high volume center, and you are yourself doing your re-TURBT, many times you don't find anything different.
Okay, this patient underwent a restage TURBT, intraoperative, there was only scar, the histopathology, there is no evidence of malignancy. Now the question is to all the panels. So would you recommend giving a BCG, HIVEC, or any other intravesical agents?
NMIBC, T1G3 with re-TURBT showing no different pathology. So yes, preferable treatment in case he agrees after a discussion is intravesical BCG therapy. I would go with 80
mg. Panel disagree with him. T1G3 with a lymphovascular invasion positive area of the panelists, they disagree. They would recommend early cystectomy, or everybody agrees with Dr. Ganesh Bakshi for BCG?
BCG.
I would suggest BCG.
Yeah. Just very quickly, 2 slides. This is actually because Dr. Ganesh, do you have any experience of BCG toxicity, the currently used Moscow strain that you are using right now?
Not of toxicity.
We do see toxicity. I'm very frank. We do see toxicity, but I think it can be handled well. Most of us in our clinics probably don't have time to ask these questions and keep the patient in touch. So I always tell people that now that I have moved on to this new place, I myself keep touch instead of even my residents keeping touch earlier, and I manage it really well. Many of my patients are taking BCG well. Some of them do have toxicity, and I have changed them to something like gemcitabine or something.
Okay, do you have any particular thing to say whether the Danish strain was more toxic or the Moscow strain is more toxic now?
It is said that Danish strain was less toxic, which was made at Guindy. But if you really go to the literature, there have been toxicities seen with Armand Frappier and lots of strains which are not in India also. So I don't know whether Moscow is the culprit, we should call it. It is said to be more toxic. There is a recent, I think Gagan had published in IGU about BCG, because the range of that vaccine is very, very different. The capacity in each 40 milligram, it is very different.
Yeah. So actually, just very quickly, when actually since the BCG we are now experiencing more toxic, we can have the other options of giving HIVAC upfront, even in high risk non-muscle invasive bladder cancer. This is a randomized trial on high risk NMIBC, BCG naive patients. A randomized trial between HIVAC and BCG, which has actually shown HIVAC with mitomycin provides comparable safety and efficacy. If you see actually the progression-free survival and recurrence-free survival actually better in HIVAC in comparison to the BCG. The take home was there is no difference between the two in recurrence-free survival, but in HIVAC the time to recurrence were actually longer than BCG, and the progression-free survival was also 95% in HIVAC and 78 to 71% in BCG. So HIVAC is an alternative option if the patient is having some toxicity, or sometimes you can also give upfront if you do not want to give BCG. There are other options like I think Dr. Jitin Jobra has already spoken about gem dosing, which has actually shown almost equivalent to BCG in recurrent-free survival and high-grade recurrence-free survival. So the dosing schedule, would you recommend to do 120 or do you give 80, Dr. Kasipi?
I have shifted to 80 most of the patients.
Dr. Rajiv?
Most of the patients.
80 or 120?
80 milligram.
Okay, you used to actually give 120 before. Actually, we have also moved on to 80 because yes. So this patient received a intravesical induction BCG 6 doses weekly, then received maintenance 3 doses at 3 months. Then take cystoscopy at 6 months, so is normal. Urine cytology is positive. So what to do next, Dr. Rajiv? Cystoscopy is normal, cytology is positive.
Well, I would do a cystoscopy and do random biopsies from areas and document it from where we have taken a biopsy, and also do the barbotage of the ureters.
Do not do some imaging before that? CT urogram maybe to see for the upper tracts?
I believe the baseline imaging has already been done. This is what I would practice, that the CT should be done before we intervene for the first time, because then later on the intervention itself will alter the imaging findings.
Yeah, before TURB to have done a CT, but during your course of the surveillance follow-up, so once
I think 6 months is 6 months is too early for me to reconsider it. If the ultrasound is not showing any hydronephrosis or the prominent ureter, upper tract, I will assume they are fine. Barbotage will be more useful rather than doing a CT scan.
And Dr. Ganesh?
So I think I would agree with him. Doing a CT or not, we'll have to take a dynamic decision.
So again, would you do a cystoscopy with blue light or NBI with random biopsy, bilateral RGP or barbotage? So the cystoscopy with NBI show 2 small recurrences, then those are actually TURBT again T1 G3. Now the options. Would you do a cystectomy now, or you do consider any other intravesical agents? Dr. Kashyap?
I would consider giving a gem site plus docetaxel combination.
Dr. Bora, do you have a different opinion, or do you agree with him, or do you want to do cystectomy for this patient?
We'll still try to save his bladder, and maybe we can give him a gem-dosi combination.
So none of you actually agreed with Dr. Jitan Joypura. He said cystectomy is always better since the patient has already received adequate BCG and
So
he has recorded 6 months. Right?
We need to have a discussion with the patient and the relatives, because they are also going to read and come. And today that would be a better thing to do. And then we should tell them that high-grade disease having such fast recurrence is going to recur somewhere again. We have other modalities of treatment, but offer cystectomy and then proceed if patients agree to the conservative management.
Okay.
I have done that myself.
This is exactly what happens around the world, and it is practical. I mean, I would say, just discuss. This is what I
think I just don't need to go into the details of again BCG unresponsive disease. So Dr. Jitan Joypura has already spoken. I'm sorry for taking a little more time, and thank you all my panelists.
Thank you, Dr. Naik. It's just that we did overshoot some time, so maybe we'll take care next time. And I sincerely thank all the faculty of this session for doing a great job. and we have had comments in the chat box, simultaneously answering many questions also, that it's a very good discussion which is going. So quick announcements. That's probably my duty as this. So as Dr. Ghosh has already said, that we will be having our first annual meeting in Uro Oncology subsection of USI. That's on 9th and 10th June of 2023. That would be in AIMS Rishikesh. And Dr. Ankur would be the one who would be actually organizing all the hospitality issues there. And there are certain highlights. So I would encourage that because this would be our first physical meeting for the subsection. And I would humbly request everyone of you to that we should try to make it a big success by being a part of it. And secondly, we would have, as I would say, Honorary Secretary highlighted, that Uro Oncology section needs as a mandate that we should be member of this subsection. So this is the clickable link. This will be circulated eventually to everyone, so that you can join hands. And that Dr. Ghosh, Chairman, has already mentioned all the highlights of what are the benefits of joining. So next webinar we would be having on locally advanced prostate cancer. Again, it will be a 1 hour format, and this time we promise that we stick to 1 hour time. I sincerely apologize for that loss of time. Thank you very much.
Thank you.
Good night. Good night, everyone. Thank you.
Good night. Thank you.